So as you know, in case of tuberculosis, we have primary tuberculosis, miliary tuberculosis, and post-primary tuberculosis. In case of primary tuberculosis, the initial focus of infection can be located anywhere within the lung and has no specific appearance, ranging from too small to be detectable to patchy areas of consolidation or even a lobar consolidation. Radiographic evidence of parenchymal infection is seen in 70% of children and 90% of adults. Cavitations in this stage is very uncommon, but it's seen only between 10 to 30% of the cases. In the majority of the cases, the infection becomes localized and forms the tuberculoma, which usually eventually calcifies and is then known as Ghon lesion. The more striking finding, especially in children, is that of ipsilateral hilar and contagious mediastinal lymphadenopathy, usually right-sided. The pattern is seen in over 90% of the cases of childhood primary TB, but only between 10 to 30% of the adults. These nodes typically have low density centers with ring enhancement on CT. So you can see here this defined, in case of adults, defined patchy or opacifications. In this case, your left side you can see this right upper lobe opacification, and your left side both lower lobes opacification. In this case, we are seeing a sample of the tuberculoma, of the Ghon lesion, which is marked with a red arrow, and multiple left and right bilateral buds more visible on the left side. Or these are round or oval masses suggestive of the calcified nodules, which is marked with a black arrow. Then we have this miliary tuberculosis, which is uncommon but carries a poor prognosis. Miliary deposits appear as 1 to 3 millimeters diameter nodules, which are uniform in size and uniformly distributed. If the treatment is successful, no residual abnormalities remain. That's very important to know. If the treatment is successful, no residual abnormality remain. Remember, this is pattern of multiple and bilateral micronodular lesions, like this one, from 1 to 3 millimeters, uniformly distributed. It's a classic image. We have another 4 or 5 differentials for this one, but it's not the main focus on this tutorial. Now remember, you need to have in consideration the history of the patient and the lab test, in this case, to confirm your final diagnosis. That's very important to know. And then we have the post-primary TB, in which the lesion should be located in the posterior segment of the upper lobes and the superior segment of the lower lobes. The post-primary TB go to produce a different type of radiological lesions, maybe in the parenchyma or in the pleura. In the parenchyma, go to produce this defined patchy consolidation. Also go to produce cavitations, which go to develop within the consolidations. And the healing results in fibrosis. The healing of these lesions results in fibrosis, which go to lead to bronchiectasis and atelectasis. So at the pleural level, go to produce pleural effusion, pleural thickening, and pleural calcification. And this is a sample of the type of the diseases. In your left side, you can see this defined patchy opacification in the right upper lobe with cavitation within this lesion. And on your right side, you will see this healing process, which is producing fibrosis of the left upper lobe and loss of volume of that lobe, producing atelectasis in this area. Spine manifestations. So tuberculosis of the spine, or Pott disease, is the most common site of the bone infection in case of TB. Hips and knees are also often affected. The lower thoracic and upper lumbar vertebrae are the areas of the spine most often affected. The lower thoracic and upper lumbar areas are the most common affected in this case. In plain X-rays, tuberculosis spondylitis can be difficult to detect in early stage because of the relative preservation of the disc space. A reduction in the vertebral height is often seen with the irregularity of the anterior superior end plate being relatively early in subtle sign. Also, you can find irregularity of the anterior vertebral margin, which is a classical appearance with TB spondylitis. But what happens in some cases? In the majority of the cases, this early stage of the Pott disease, there should be young people who will come into your consulting room with back pain. When you go for the X-rays, in the majority of the cases, the X-ray is negative. But what happens? You have to put a special attention to the soft tissue and look for any density variation in this case, and then look for these subtle signs of bone erosion or any end plate sign or end plate sclerosis can guide you to your, in this case, this type of terrible disease. So you have to pay attention on that and always back up with a lab test. Always back up with the lab test. But first, you have to think on this kind of the disease. Otherwise, you will not able to diagnose Pott disease. It's as simple as that. And then when the patient comes a few months later, it's too late, because sometimes they are coming with damage already of the spinal cord. So it's very important to try to diagnose this type of the disease in the earliest stage. And here in West Africa, it's very common. It's very common. So these are a sample of the Pott disease or tuberculosis spondylitis. So you can see there is a total vertebral destruction in some cases with fusion of the vertebral bodies. Total vertebral destruction with fusion of the vertebral bodies, and the physical examination you go to appear this kind of kyphosis. In other cases, you're going to see this huge paravertebral abscess. These cases are easy to diagnose. But like I say, the trick is to diagnose the disease in the early stage so we can avoid any damage with the correct treatment to this patient. So for further investigation, we use cross-sectional imaging to assess better the extension and involvement and particularity for the presence of any epidural component and cord compression. MRI is the modality of choice for this case, with CT with contrast being a distant second. Features include irregularity of both the end plate and anterior aspect of the vertebral bodies with bone marrow edema and enhancement seen on MRI. The paraspinal collections are typically well circumscribed with fluid centers and well-defined enhancement margins. So there are samples of the MRI. You remember, they go to attack the lower part of the thoracic vertebral bodies are made from T10 to T12. The upper part of the lumbosacral spine that mean between L1 and L2. So just pay attention. You have to be able to diagnose this terrible disease in the early stage so you can save the patient. Intraperitoneal manifestations. Tuberculous peritonitis is a form of extrapulmonary tuberculosis affecting the peritoneum. It is frequently seen in association with other forms of gastrointestinal tuberculosis. Radiological signs include ultrasound, in which we are going to see a diffuse peritoneal thickening, ascites, adhesions, omental and mesenteric thickening, increased bowel wall thickness, and lymphadenopathies. So these are samples what you're going to see in the ultrasound. You can see this large amount of free fluid in the intra-abdominal cavity. So it's basically when you request for the ultrasound, so you were to receive this report with this large amount of fluid, sometimes with the majority of the cases with sectations. So when you receive this, depending on the clinical, like I always say, clinical history of the patient and the lab test, you can be sure, almost be sure, you are in the presence of intraperitoneal tuberculosis. It's very important to know. Eventually, you also can request, depending on where you are, a CT scan. The CT scan will to show something similar, but in this case, we want to see more with more details the pathology. So we are going to see a nodular or symmetrical thickening of the peritoneum and mesentery, a normal peritoneal or mesenteric enhancement, ascites, enlarged hypodense lymph nodes. In addition to this, there can be more specific imaging features seen with individual types. We have the wet type, dry type, and fibrotic type, just for your general knowledge. So this is an example of the CT scan. We can see this large amount of free fluid, all these hypodense areas. In this case, loculated areas. So remember, in case of the intra-abdominal tuberculosis, you will receive this report of this large amount of free fluid. We're talking about the peritoneum, specifically about the peritoneum, because we have also a renal tuberculosis. You can see this a calcification within the kidney, and sometimes you can see also the ureter is calcified. But it's more common in the peritoneum. Here in this part of the world, is more common in the peritoneum. In Ghana, we see a lot of cases with this kind of tuberculosis manifestation. So you always you have this patient with ascites, you always think in this tuberculosis infection.